Sir, we are live, so with your due permission, shall we start the session?
Sure.
A very good evening to all of you present on today's session. I am Nishita from IGCP Group. Welcome everyone on Challenges in Management of Irritable Bowel Syndrome. Let me share an overview of today's session. Managing irritable bowel syndrome, that is IBS, poses multifaceted challenges primarily due to its diverse and fluctuating symptoms that vary among individuals. Effective IBS management requires personalized approaches, making it complex for healthcare providers to navigate treatment options and lifestyle modification. Additionally, the chronic nature of IBS necessitates ongoing care and patient education to enhance the quality of life for those who are affected. And to present this topic, we have with us none other than Honorable Dr. Ramesh Ruprai sir. I am very much honored to welcome Dr. Ramesh sir on today's session. Sir has done MBBS, MD, DM in gastroenterology. Sir is also the former professor and HOD of gastroenterology at SMS Medical College, Jaipur. Now, without wasting any more time, I would like to hand over the session to Dr. Ramesh Ruprai sir for his precious lecture. Sir, over to you. Please proceed.
Okay, thank you, Nishita, for a wonderful outlook of the challenges which are being faced in diagnosis and management of IBS. Yes, truly it is one of the commonest diseases or symptom complexes which we come across, and that makes it very difficult for clinicians to give the final diagnosis and then to achieve the very good management. And as you have rightly told, that it is to be personalized according to the need of the patient, symptoms of the patients, and we have to console them that, yes, you have to make some lifestyle changes, and out of them, anxiety and management of the depression is one of the most important one. Therefore, we'll be taking up a very, very common case which we encounter in our clinical practice. Here I am presenting a case of Mr. HM, who is a 40 years old male presented with 10 months history of recurrent mild to moderately severe colicky pain in upper abdomen. Recurrent mild to moderately severe colicky pain. Pain occurred mostly after meals with lot of distension of abdomen with flatulence. This was partly relieved with the passage of small frequent stools with lot of mucus. There was no weight loss, no fever. One of the important thing is the pain does not occur in the night, except very severe patients who have some pain in the night. Otherwise, absence of nocturnal pain brings you closer to the diagnosis, and the rectal bleeding is not present in these patients. Adit. Slide to Patient also complained of the postprandial fullness, retroesternal burning, and belching. These episodes of pain and frequent stool occurred for 5 to 7 days in a month's time, varied in severity of pain and bowel movements. So you come across such patients very commonly, and there are some lower GI symptoms, there are some upper GI symptoms. That brings us closer to this, that IBS is not a disease of the colon or small intestine. It also involves the upper intestine also. As you can see, the patient has got postprandial fullness, retroesternal burning, and belching. And episodic pain is also an important part of this. So these are the common symptoms which is. So what should be the diagnosis? And this diagnosis is it chronic amoebiasis? Because most of these patients also complain of mucus in the stool, and they have frequency of the stool, and they always think that they have a chronic infection in their body which is causing this. So chronic amoebiasis used to be a common diagnosis, but you do a colonoscopy and there is no abnormality at the colonoscopy which rules out chronic amoebiasis. So probably the patient is suffering from irritable bowel syndrome. So lot of challenges in the management of irritable bowel syndrome are usually encountered by the physicians, and we'll like to dilate on many of these challenges, and we'll take up one by one. So one of the most important things is 10 to 20% of population shows symptoms related to irritable bowel syndrome. Most of these patients do not come to the clinicians. Only 10 to 20% of patients out of all the whole lot will come to physicians, and out of them also, those with severe symptoms will come to a gastroenterologist for opinion. So it's a common disease, but many of times it is ignored because they are mild symptoms. So we are seeing only an iceberg of the symptoms and complex of the patient and IBS. In India, also the prevalence is almost the same, and it ranges from 4.2 to 7.9%. And visit to doctors, 80% are coming to the primary care physicians, and 20% come to the gastroenterologist. So we usually encounter only very few number of patients of IBS because they come to the physicians first. If you come to the symptom complex, this not only affects the bowel movements or pain abdomen or something, it also affects the emotions. And this picture by Sarkar showed in Piku that motion se hi emotions hai. If you have a good motion, then you have emotions are good. And you can see the plit on the face of this gentleman, Amitabh Bachchan, in this picture, Piku. So we'll be taking up all those symptoms which are being depicted by him, and we'll be encountering the plethora of symptoms. So IBS has got plethora of symptoms, and you can see pain abdomen is the central part of diagnosis. If a person has got pain abdomen, then only you can make the diagnosis of IBS. So most of these patients have incomplete evacuation. They have straining. They have altered bowel habit, that means either constipation or diarrhea or mixed type. They have concomitantly heartburn, and dyspeptic symptoms are there. Nausea and vomiting is there, and gas and flatulence is also one of the important part of the diagnosis. But other than related to GIT, there are some extra intestinal symptoms also which are seen in the pink color here. Then you can see that there could be psychosexual symptoms, there could be urinary frequency, there could be fibromyalgia, or in the ladies, it could be in the premenstrual time, they have worsening of their symptoms like constipation. These plethora of symptoms have been synthesized, and a number of experts had collected, gathered at one place, that is Rome, and 1, 2, 3, and now the fourth criteria, Rome 4 criteria for the diagnosis of IBS have been synthesized. They say that recurrent abdominal pain at least 1 day per week on an average in the past 3 months associated with 2 or more of the following. What are these 2? That is, the recurrent abdominal pain is related to defecation, change in frequency of a stool, or change in the form of a stool. And the symptoms onset should occur at least 6 months prior to diagnosis of symptoms should be present during past 3 months. So it is a important thing to find out that this patient has got a pain abdomen, and that is related to defecation. If the pain is not there, most of these patients will have either chronic constipation, that is functional constipation, or they have the functional diarrhea. So it's a function of the intestine which makes, and if the pain is present, then you have to say that this patient is having. So irritable bowel syndrome encompasses plethora of symptom complexes. No clear diagnostic marker is there. There is no marker, a biomarker also which is there. Therefore, the diagnosis is based on characteristics symptoms which we have labeled just now in the room 4, making it a positive diagnosis and not a diagnosis of exclusion. That you do many tests and all the tests are normal, then you say that the patient has got IBS. You can also make the diagnosis of IBS only on the characteristic symptoms which we have just labeled. So what are the symptoms of IBS which are commonly observed? Abdominal pain is in the center of the diagnosis. It is prerequisite for making the diagnosis of IBS. Its variable intensity, mild to moderate to severe, occasionally disturbs the sleep at night, as I told, but usually to make the diagnosis, one should ask the pain does not occur in the night. Location could be lower or upper abdomen. Frequency is episodic, crampy. One of the important things is it's a colicky pain which is there, maybe superimposed on a background of constant pain. It increases after the ingestion of food, and stressful events worsens the symptoms of IBS. And in the premenstrual cycle, also the pain becomes worse. So one of the important thing is that if there is a precipitating stressful event, like somebody dies in the family, some loss has occurred, or some a major trauma to the patient has occurred, then he comes to the physician. That means at that time his symptoms are. So one of the important thing is that there is a visceral hypersensitivity which is associated with the stressful event which has occurred in his life, which brings him to the patient, to the doctor. Altered bowel habit, it is the most consistent clinical feature of IBS. The most common pattern is constipation predominant, that is IBS-C, constipation alternating with diarrhea, IBS mixed type, diarrhea predominant, IBS-D, unclassified as IBS-U. Bowel pattern are highly unstable. That means a patient may have constipation sometime, there can be changing to diarrhea sometime, it could be mixed type. So 75% of patients change their subtype. 29% of patients switch from IBS-C to IBS-D over a period of 1 year. But this chart, which is called as a Bristol stool form of scale, should always be present at the table of the physician, which will help him that if the type 1, type 2, and type 3 stool is present, then it is called as IBS-C. 4 can be classified either as diarrhea or as the constipation type. So you show to the patient that do you have these small scabuli? Do you have a long piece with the irregular surface, cracks on it, or that is a smooth stool which is there, long piece which is there, then it is called as IBS-C, as has been depicted here. So it is going to be very important for the physician to show to it to the patient. He will be able to tell whether he has got IBS-C or IBS-D, or he can say it is sometimes IBS-C, sometimes IBS-D, and it is a mixed type. Constipation means differently to different people. Sometimes patients, when they are straining, which is almost about 81% of patients, when he is straining and straining, nothing comes out, and there is a good song with that means you have something which is clogging the passage, and he's straining and not getting. So secondly, many patients can say, if they have a hard lumpy stool, they will say, yes, I pass very hard stools, and that makes him feel constipated. That again could be incomplete evacuation, which is there. That means he passes a small amount and then he is straining, and incomplete sense of evacuation is there. A stool cannot be passed. That means he's sitting for hours together and he's unable to pass the stool. And he is associated with bloating. Then also he's. But for a physician, usually a physician thinks that less than 3 bowel movements per week could be the constipation. This is for the Western population, but for straining, hard, lumpy stool, incomplete evacuation, stool cannot be passed. Constipation. And IBS-C, at first constipation may be episodic, but eventually it becomes continuous and increasingly intractable to treatment with the laxatives. You go on increasing the doses, you go on changing the laxatives, but still the patient is constipated. Stools are usually hard, pellet-like, with narrow caliber or dry stool. Normal bowel movement, if you see, you get up in the morning, you are yawning, then you take a cup of tea. This sends stimulus from the stomach through the vagus nerve to the brain, and from the vagus nerve, it is sent to the left, the whole of the transverse colon, and also to the descending colon and to the rectum. Then there is a sensation, and the external sphincter and internal sphincter both are relaxed, and one passes the stool normally. So this is called as a mass reflex. That's why our parents used to say, drink 2 glasses of water in the morning and you are going to have good stools. It is not that this water is going to the large intestine and pushing the stool. but it is only a reflex which is given through the vagus nerve. IBS, a sense of incomplete evacuation, as I just mentioned, thus leading to repetition in a short time span, sense of obstruction at the anus, as if there is a growth is within a day, initial hard stool, then formed stool, and then loose stools also can be there in many of these patients. And stool frequency could be 1 to 3 per day, or less than 3 per week, or occasionally once in 4 5 days. So it all depends on the patient, and you have to take the history in the greater detail. And you can see how this gentleman who is straining, you can see from the epiglottis to all the abdominal muscles and to the exit point, he's straining hard, and all the nerves are acting, all the muscles of the body are acting. He's pushing his diaphragm downwards. So you can see how difficult this process of evacuation is for this patient who is having incomplete evacuation and is straining hard. Diarrhea prevalent IBS-D is a small volume loose stools. Volume is less than 200 cc per day. So you have to ask if it is a diarrhea of the organic disease. Usually ask him the amount of food you take, but the amount of water, amount of the stool which comes out is about 1.5 times to 2 times or more than 200 cc. Then only you can say it's a organic diarrhea. Otherwise, usually it is less than 200 cc per day, and it is very small in quantity, and frequency is there. No nocturnal diarrhea is there, as I just mentioned. With the constipation also, it is aggravated by emotional stress, postprandial. There is an increased gastrocolic reflex. As soon as the patient takes food, then he goes to the toilet, rushes to the toilet with pain abdomen. So increased gastrocolic reflex is a very important point in the history taking, with lot of mucus which is passing, but there is no malabsorption, there is no weight loss. So it's very important to understand that even though the frequency of stool is there, even though there is a loose stool which is there, but the amount of stool is not large, and there is no malabsorption, and there is no weight loss. So these all important points should be asked to the patient, whether he is passing large amount with the frequent unformed stool, or the patient has got weight loss, or he has got malabsorptive symptoms, which is, that means undigested or food particles are passed downwards. Mixed type, as you said, that sometimes it may be hard, that means 2 to 3 times per day, or later on 3 to 4 loose stools may be there. So in mixed type, sometimes constipation, and you have to also ask for the symptoms of fever and the gola formation, which will tell you that possibly this patient has got sometimes diarrhea and sometimes in constipation, and it could be tuberculosis. So you have to also exclude the presence of tuberculosis in these group of patients who are having alternating diarrhea and constipation. Gas and flatulation is a very, very common symptom with these group of patients. Distension, postprandial, flatulence is there, increased places of flatus, often foul smelling because the constipation, that means the hard stool is there and bacteria is acting on them, leading to foul smelling gases which have been passed. A belching also is there. There is a postprandial visible distension which could be there because of the dyspepsia. Occasional patient produces more gas. Most have same amount of gas in normal as if normals, and have increased sensitivity to normal amount of gas. That means a normal person, if he has got 200 cc, but this 200 cc is felt by the IBS patient as a large amount of gas in their abdomen. Another important thing I just mentioned, that upper GI symptoms, that means dyspeptic symptoms, are also common and with the IBS, and there could be overlap. 25 to 50% patient complain of dyspepsia, heartburn, nausea, and vomiting, suggesting involvement of upper GI along with the colon. Prevention of IBS, higher energy among patients with dyspepsia is there, and among the patient of IBS, 55% patient will have symptoms of dyspepsia. So that means the whole gut is involved in this patient. Understanding pathophysiology is a very, very difficult thing because the symptoms are so varied from upper abdomen to the lower abdomen, and it is involving the whole of the gut. There are extraintestinal symptoms, and pathophysiology is a little bit less understood in most of the times. It started with the psychological stress, somatic syndrome, no entry, no entity. That means people said it is not a disease. So they used to call they have a somatization of their syndrome. Then it was called that brain gut axis is there. That means the brain is sending more impulses to the gut, and gut is passing. After that, altered gut microbiota was also labeled mucosal inflammation that increased intestinal permeability, and now the gut brain axis has been found and has been labeled. Now, this disease of IBS is now called as gut brain disorder syndrome. So, probably in Rome 5, we are going to have a change in the irritable bowel syndrome to gut brain disorder as IBS. So probably some change is going to occur. And as I said, pathophysiology of IBS is poorly understood. It is multifactorial. And as I just mentioned, if there is a leaky gut, that means when the bacteria are high in amount and they are pathogenic bacteria which are there, they causes loosening of the tight mucosal junction, and there is a leaky gut. That means the toxins and the various types of cytokines are released into the gut. It leads to visceral hypersensitivity, and psychological or anxiety, panic, depression, somatization is common. There could be disorders of gut-brain interaction, which is also common. They have autonomic dysfunction, and they have some motility disorder. One of them, as I just mentioned, dysbiosis, genetics, susceptibility of the environmental insults in the psychological trauma or other things leads to altered permeability of the intestine. Leaky gut is there. Increased antigen presentation is there to the gut. It leads to activation of the mast cells, leads to altered enteric, neuronal, and smooth muscle functions. That means the smooth muscle is not able to expel the stool, and there could be overactivity of the neurons as well as the smooth muscles, leads to the symptoms of IBS. But these mast cell activation can directly have systemic cytokine and chemokine release, leading to extra GI symptoms, as I just mentioned, that they have dyspareunia or increased urination, they have psychosexual problems, they have some of the premenstrual symptoms which are present in these group of patients. So it is a very, very ill understood thing. And the same has been depicted in this cartoon that which shows that the tight mucosal junctions, which you see over here, are being broken down by the dysbiosis of the bacteria, leading to a antigen presentation, increased permeability, and leaky gut is there, and the mast cell activation takes place, leading to the altered symptoms of the gut, leading to pain, abdomen, diarrhea, or constipation. So it is a little bit ill understood thing, but some of these things are coming to fore, and we can understand how the symptoms are occurring. So pathophysiologically, if you see in a patient who has got some psychological disturbance, there is altered motility is there, distension and spasm of the gut is there, visceral hypersensitivity is there, leading to pain with the smallest stimuli, leading to bloating, and neurotransmission imbalance is there, infection and inflammation of the gut is there. So it's a interplay of various types of pathogenic bacteria. And I just mentioned that gut-brain axis now is an important thing because CNS modulation is occurring through the gut. Initially, we used to say brain is controlling the gut, but now we understand that the gut is controlling the brain to produce the symptoms. So in this patient, when you see a normal person, from the dorsal root ganglia, which is over here, from here the C fibers carry the stimuli, which is reaching to anterior cingulate gyrus, which you can see over here, right? And this is down regulating, this is controlling the prefrontal cortex. That means all those stimuli which is coming in normal person are being down regulated. So there is no increased visceral hypersensitivity. But in patients with IBS, There is a rectal stimulation nociceptive receptors are there. That means the smallest amount of gas or stimulation in the rectum leads to high impulses to the dorsal root ganglions, and it reaches to the brain, right? This leads to cortex activity to decrease, and uninhibited prefrontal cortex activity is there. That means uninhibited. So small stimuli, large reaction. So there is increased perception, increased vigilance, hyperalgesia state, which is there in these group of patients. So it is now told that it is a gut-brain axis disorder. And this can be seen in the functional MRI also. That means you can see in the normal people, you have anticingulate gyrus, which is controlling the prefrontal cortex. But in IBS, the anticingulate gyrus is not able to control, and there is a prefrontal cortex is having a lot of stimulation, which is there. The red one, which I've seen over here. So it is very important to understand that there is a increased perception of the pain and distension of abdomen, and the vigilance is there, and the patient is having more symptoms with the smallest stimuli. Another very important thing which has been noticed in many of these patients with the IBS, that patients who have infection or infectious diarrhea, after 3 to 4 months or 6 months, they develop the features of IBS. That means bacterial gastroenteritis, which is there, leads to 25% patient will develop features of IBS. In IBS patients, 33% have experienced chronic GI symptoms before development of chronic IBS symptoms. They develop more in females and in young age than older group of patients. So this post-infectious diarrhea is common in these group of patients, 25% of patients, but who are going to develop the IBS features will just enlighten. So risk factor for IBS development in post-infection diarrhea is prolonged duration of acute gastroenteritis. Usually it lasts for 5 days, but if it is 7 to 10 days or 15 days, toxicity of the infecting bacterial strain, if it is having high toxicity, it is going to produce post-IBS diarrhea or constipation. Smoking, mucosal markers of inflammation. Depression is very important to understand that they have an underlying depression or anxiety. They have hypochondriasis, adverse life events in the preceding 3 months. The microbes involved in this initial infection could be Campylobacter, Shigella, or Salmonellosis, which are the common infectious agents. So post-infectious diarrhea is very important. Altered gut flora, it is very controversial whether a change in the bacterial spectrum or overgrowth will lead to IBS symptoms. Some studies have observed molecular profile of fecal microbiota in the IBS patient. That means lactobacilli are absent and polycella are decreased. It is not clear as to this is because of consequence or result of constipation or diarrhea. So we do not know as to which is. But another important thing which I just mentioned earlier, in the IBS, psychological features, that means 80% of patients of IBS who are referred for the diagnosis and treatment have some abnormality, psychological abnormality. No single psychiatric diagnosis is predominant. Most patients demonstrate exaggerated symptoms in response to visceral distension. That means you distend the balloon 50 milliliter in the rectum, it is going to have a very high sensation of gut motility, which will be increasing. Psychological stress influences pain threshold and alters sensory threshold. A lowered sensation threshold alters visceral sensitivity or perception, as I showed in the gut-brain axis, which is important to understand. But symptoms are going to make the diagnosis of these patients. So do not do a lot of investigations. More investigation you do, more they are normal. The patient loses his interest. He understands probably your diagnosis. You are not able to make the diagnosis. All tests are coming normal. You are going and ordering for test to test. So individualize the investigation to one particular patient. Medical and psychological circumstances should be analyzed. Do not apply same diagnostic approach to all. Do not act like a Sherlock Holmes. taking care of one hair and making the diagnosis. So it's very important that you do not become Sherlock Holmes and you do very, very minimal tests which are going to exclude organic diseases. Another important thing is you should be sympathetic and soft to the patient. Don't say that you do not have any disease, you have got only problem in your brain. So that he will run away from you. So you have to be sympathetic, empathetic, and soft to the patient. Try to think that he is having symptoms which are real. We'll analyze this thing little bit in greater detail. The primary test for diagnosis of IBS, the test which primarily aim to rule out other differential diagnoses of IBS include full blood count if anemia is there, unexplained anemia is there, WBC counts are high, ESR is high, CRP is high, and many of these patients of diarrhea have celiac disease. So, two celiac disease serology in these STTG is a common test which should be done. Thyroid function test should also be done in many of these patients. Those patients with hypothyroidism have constipation, and patients with hyperthyroidism have diarrhea. Stool tests for parasites may be done, but nowadays it is seen that parasites are very occasionally seen. A sigmoidoscopy should be done, and X-ray abdomen is very vital in these group of patients. Why? Because the stool, if it is present in the left side of the colon and rectum, which will say, and you can tell your patient that you have got IBS-C, and because of this, your symptoms are there. And if it is a small amount, a small gut is dilated, you can say the patient has got diarrhea. So there are some red flag signs. Red flag signs means all those patients who have these symptoms should be investigated with various tests to exclude the diagnosis of which is not IBS. So if a patient has unexplained anemia, unexplained fever, persistent diarrhea, rectal bleeding, severe constipation, weight loss, nocturnal symptoms of pain, abdomen, and abnormal bowel function, family history of GI cancer, inflammatory bowel disease, or celiac disease, or if the new symptoms occur in a patient of 50 years or more, then you should do all the investigations to exclude a organic disease in these group of patients. Diagnostic approach is patient with suspected symptoms, take a detailed history, do thorough examination, red flag signs should be excluded, and symptoms meeting Rome 4 criteria, if they are there, do not investigate further. If they are some of the red flag signs are there, but if they become normal or they are not they're absent, do not do many investigation. IBS is a common thing, and if the cause is detected, you can think that IBS is unlikely. Look for organic pathology, investigate and treat accordingly. And rectal carcinoma is one of the commonest thing which one should be excluding. And tuberculosis of the intestine in this India is important. Alternating constipation and diarrhea in patient with Crohn's disease is also there. So you will have a high CRP, high ESR, and fever, or these are the symptoms by which you can identify Crohn's disease or ulcerative colitis. So management of IBS is very important to understand, because patient is not interested what diagnosis you have made. He is interested in getting his treatment. So you should be helpful in making the diagnosis of IBS and then help the patient to overcome his symptoms and explain all these symptoms to him in greater details. So clinical experience suggests accept patient symptoms and distress as real, not symptoms as manifestation of excessive worrying or somatization. So you should be sympathetic to him and say and accept his symptoms as real, and distress also as real, and should not say that you are worrying too much, that's why your symptoms are there. So we must have on the background that he has got some psychological abnormality and try to analyze them. So as I just mentioned, plethora of symptoms is there. So you have to analyze in greater detail all these symptoms which I have just mentioned. Patients usually will bring a very big list of his symptoms that, as you see in the PICU, he was telling his daughter in the office that today my morning stool was like pencil-like stool, then sometimes it became clumpy stool, other time it became a very, very hard stool. Like this, they have symptoms which they'll put them. They are the long petitioners, they are called as. And they bring so much of investigations done by other doctors that a doctor is so much puzzled how to synthesize that what this patient is suffering from. But patient is not interested in this. He's interested in the management. So doctor-patient relationship is very important. So I usually say that patient hearing of patient's complaint, patient hearing of patient complaint is the foremost thing. Very patiently listen to with sympathetic mind, you should listen to the patient, take his symptoms as real. Don't say it is worrying the symptom, worry for symptoms. This will win the trust of the patient, maximize the efficacy of the treatment, and minimizes doctor shopping. Usually you see that IBS patients go from one doctor to another to another one. And this is called as doctor shopping. And this is very common with IBS because the doctors do not give time. And anybody of you who will give time to the patient, he will stick to you. Always provide a patient with a plausible model of the diagnosis. Say him that this is a gut brain disorder, what is happening to your brain, why this thing is happening, and you explain why constipation is occurring, why diarrhea is occurring in you. This will win the trust of the patient, the relationship, and the patient compliance to your treatment high. So patient trust relationship should be which should be the cornerstone in the management of IBS. Approach includes acknowledging patient symptoms, educating patient about the disease, reassuring the patient that he's not likely to develop colon cancer. This may improve the treatment outcome. Therapy is directed towards the main symptom, which is the pain abdomen, should be done by most of the physicians first, and then they should target the altered gut motility. That means the patient have got constipation or diarrhea or mixed type. Then they should, if the patients are having very severe symptoms, altered gut sensitivity should be done. Then altered CNS or processing of stimuli should be assessed and their symptoms should be analyzed. And then they should be given appropriate treatment for his brain activities or psychological abnormalities. Pain abdomen, bloating, and increased gastrocolic reflex should also be answered. So patient severity of symptoms is diagnosed or classified as mild, moderate, or severe. The prevalence of the mild symptoms is 70 to 80%, moderate is about 25%, and severe symptoms who come to the gastroenterologist or the tertiary care center is only 5%. Correlation with gut physiology, that means you can explain why gut motility is low. That's why you are having constipation. Your gut is contracting more, so you are going to. So you can have a correlation with gut physiology. In severe one, it is most of the times is psychological stress which is producing the symptoms. So correlation with gut physiology is not there. Symptoms which are constant are usually not present in mild one. They may have sometimes symptoms, sometimes not, but the severe patient will always have symptoms which are constant. Psychological difficulties are highest in the severe one. Healthcare issues are highest in them. The practice is primary, a specialty, a referral to tertiary care center in severe patients. So non-pharmacological approach is educate patient on importance of diet, exercise, and toilet training. Diet means he should try to drink a lot of water. He should do exercise to give strength to his abdominal muscle and diaphragm. Respiratory exercise should be done, and toilet training should be done. What do we mean by toilet training? That means emphasis. This is, as you see in the red one, the emphasis should be put on recognizing and responding to a urge to bowel movement early in the morning. That means as soon as you have a urge that I'm having some pain abdomen and now I should go to the toilet, if you respect that, you are not going to have many symptoms and your symptoms will be relieved. So if the patient has got constipation, it is because of the dysrhythmic contraction of the colon which are simultaneous and not progressive. That means they contract, but this time this is contracting, this is contracting. So there is a simultaneous contraction which is there. It is dysrhythmic contraction. Slow gut transit is there. Increased sensitivity of the in the colon is there. Impaired defecation is straining is there. And this X-ray you can see that the whole of the colon. Take a minute. This has become like this. So this X-ray shows a lot of fecal matter which is present in the left colon and in the transverse colon as well as in the right colon. Another important thing which we should try to understand and make the patients also understand, those who are elderly people, we have to understand that even the Western people have started understanding that squatting position in which most of the Indian toilets are made and most of the Indians defecate in that one is very helpful in controlling their constipation. And this is happening. That means when a patient is sitting in the 90-degree position on a commode, that means at that particular time, the angle which you can see on the this colorful diagram here, that means the angle is a very acute angle which is there, and the puborectalis is contracting very fast and making the patient not to defecate even if the rectum is full of the fecal matter. So there is a tightening which occurs at the due to puborectalis muscle which is contracting very high, and then you have the rectum in which if you put a small stool underneath your legs and you bend forward, that makes you in the squatting position and you are able to pass the stool, which is very important. Adding plenty of water and adding fiber is also very important. And this gut regulation takes place. If you are having diarrhea, you are going to have a good formed stool. If you have constipation, this is increasing the bulk of the stool, and contractile force of the muscle is increasing, and there is increased propulsion. This facilitates defecation. Dose is 2 teaspoonfuls of the Irritable husk to be taken with meals. It is very important to take with meals 2 times in a day. Fiber not useful in patients who have a stool frequency less than 1 per day, and it is associated with bloating, worsening of the symptoms. So you should judiciously use your constipation patients, the fiber. Use fiber slowly in incremental doses. Constipation dominant IBS, polyethyl glycol has been found to be very useful. A sachet of 17.5 grams, which is given in 300 milliliter water, 2 sachets in the night. In many patients, it is very helpful, but it increases the frequency of the stool per week, decreases the stool consistency, it decreases laxative consumption, decreases number of dropouts, and it does not improve pain of IBS. But in the contrary, I have done a studies in which I do a disimpaction with the help of the pen. What we do is that we give sachet of 17.5 grams in 250 milliliters of water every 50 minutes till all stool is cleared from gut and clear water is defecated. On the second day also, we do the same way, and lesser amount of the polyethyl glycol is being used. On third day also, same process is done. Every day, the dose of PEG is required to clear the gut goes on decreasing, and the pain also disappears in most of these patients. So such a method is useful in alleviating symptoms of constipation in almost about 95% of patients, decreases gastrocolic reflex, decreases postprandial distension, decreases pain, no need of antispasmodics after 7 days, decreases flatulence and gas formation, improves overall global IBS-C symptoms, improves quality of life. Side effects are also there. Occasionally, the patients have electrolyte disturbances, or there is a patient develops dehydration, weakness, imbalance, and mild fatigue could be there in these groups. But this is one of the best constipation relieving drug, the glycol or the PEG solutions or PEG powder, which has been used. Osmotic laxatives like lactulose have been found to be very useful, given as about 25 milliliters in the It is non-absorbable carbohydrate, causes increased gas production, but it is quite useful in patients with the IBS. Stimulant cathartics like Biscodile and Senna are usually good for initial period, but they produces cramping and tachyphylaxis. Tachyphylaxis means you are going increasing the dose of the Senna in these group of patients, and occasionally it so hampers that it damages the enteric neurons, and it is very unfortunate event that the colon becomes like a lead pipe. It has been reported in NEGM by one of the Indian doctors. Sodium picosulfate has been found to be a stimulant cathartic, commonly useful in most of the patients. It produces a stimulation of the muscles and leads to the passage of the stool, which is smoother and better. Pain, as I just mentioned, is the most important thing which should be addressed. Relief can be achieved by breaking the vicious cycle of pain, which leads to spasm, and spasm leads to pain. So you have to give some antispasmodics, though not many good antispasmodics are there, but I will explain you with two of our studies which we have done, which with the antispasmodic, and that has been found to be useful. I'll just explain them. Antispasmodic relaxes smooth muscle in the gut, decreases contractility, decreases gastrocolic reflex, decreases meal-induced colonic motility, decreases postprandial urgency and cramping. Drugs should be taken 30 minutes before the meals. It is very useful. RCTs have shown to improve the global symptoms of pain. Meta-analysis suggests that these agents decrease pain, but they do not have any effect on the stool frequency and consistency. And all those antispasmodics which have been commonly used, that means the cholinergic agents as antispasmodics, are associated with dry mouth, blurred vision, fatigue, and urinary hesitancy. So these cannot be given for a very prolonged time. Hyoscine, clinidium bromide, dicyclomine is most commonly used in Indian market, 10 to 20 milligrams 4 times or 3 times per day. Mebaverine is another very important drug which has been prescribed by most of the physicians, 135 milligrams 3 times daily. Otylium bromide, simaprotein have been used, but they are very costly, and their effect is also not very good in patients with the IBS-C. So it has not been found to be very useful in these groups. But the most commonly prescribed drug combination is clinidium bromide, chlordiazepoxide, and along with that, dicyclomine added. So 3 drugs combination has been found to be very useful. So clinidium bromide, 2.5 milligrams, chlordiazepoxide, very low dose of antidepressant has been found to be useful in many of these patients. Antispasmodics, which are directly acting on the smooth muscles, out of them, rotavirine is available in India, mebaverine is available in India, and 2 ones are not available in India. Dicyclomine is commonly available. Hyoscine is not very useful. Camilofin has been found to be useful, and it is available in India. And clinidium bromide is available in India, is mostly used by all the physicians. We have done a lot of work on rotavirine and mebaverine, which have been quoted in various journals also. So rotavirine, an isoquinoline derivative, is a potent spasmolytic drug, act directly on the smooth muscle and is devoid of anticholinergic side effects. It has got dual mechanism of action on the smooth muscle. It inhibits the calcium calmodium complex and inhibitory effect on the PDE4, that is phosphodiesterase enzyme system, and it's been found to be very useful as it is acting mostly on the smooth muscles of the gut. We did a study which was efficacy and safety of rotavirine hydrochloride in irritable bowel syndrome, a randomized double-blind control study, and which was published in 2014, which has been included in the American College of Gastroenterology journal. So brain frequency and severity was decreased in 77% of patients, rotavirine group compared to the placebo group. That means 30%. Significant improvement in the global relief of abdominal pain as perceived by the patient and doctor was there. A good comparison was there. So improvement in the global relief of symptoms was also there. So here you can see from second week, third week, and the fourth week, rotavirine is producing almost about 80% relief in the pain and the severity goes on decreasing in these group of patients. Relief in pain in frequency and severity. And global assessment of relief is perceived by patient and clinician is nearly similar. So improvement in the stool frequency is also there. Previously, studies with antispasmodic have shown that stool frequency is not affected. We showed that significant improvement in stool frequency in 44% patients with rotavirine group as compared to 15% in the placebo group. So we concluded that 4 weeks treatment of rotavirine improves abdominal pain and overall global symptoms in patients with IBS. Rotavirine is well tolerated without any major side effects. And American College of Gastroenterology monograph on the management of irritable bowel syndrome has included rotavirine. So they say antispasmodic and peppermint oil in IBS. We suggest studied antispasmodics like botulinum, pinavalerium, hyoscyamin, cimetropin, rotavirine, dicyclamine. So first time rotavirine has now been included in the management monograph of American College of Gastroenterology for overall symptoms improvement in IBS. We did a comparative study to compare the evaluation, the efficacy and safety of rotavirine versus mebavirin, which is the most common drug prescribed for irritable bowel syndrome. This was a double-blind study which was published in 2021. And this work has been included in the Indian consensus statement on irritable bowel syndrome and says antispasmodic drugs in the management of IBS in randomized controlled trial of 200 patients with Rome 3 criteria diagnosed IBS. The authors found rotavirine was superior to mebavirin in alleviating pain and stool-related symptoms. So it is important to mention that this is a very good drug which can be used. Antidiarrheal drugs for diarrheal patients has been found to be useful. Loperamide has been found to be very useful in this group of patients. It can be used for a prolonged period of time, and this decreases the number of stools, and the pain also is reducing. Overall, the trials suggest that loperamide was more effective than placebo for treatment of diarrhea, not for treatment of global IBS symptoms or abdominal pain. Antidiarrheal agents administered as an needed basis symptom is preferred to a regular scheduled dosing in patient with diarrhea. Patient with consistently developed diarrhea after meals may benefit from taking a dose before the meals along with the antispasmodic rotavirine. Loperamide should not be used in patients with constipation with frequency. Adjuvant therapy, but these drugs are not available in India. Linaclotide has been found to be very useful. This is a guanylate cyclase C agonist. That means this drug activation of the GCC triggers secretion of fluid, sodium and bicarbonate into the lumen of intestine. When so much of water, sodium and bicarbonate comes into the lumen, it accelerates GI transit and reduces visceral nociception. Dose is 290 microgram given once daily. Significantly improves abdominal pain. Is very useful in patients with clotide, not available as yet in India. Placanotide, which is a similar GCC agonist, is going to be marketed in India short in about 2 months' time. And this is very useful drug as linaclotide in constipation, predominant IBS. Lubiprostone has been found to be useful. It stimulates chloride channel in apical membrane of intestinal epithelial cell. Chloride secretion induces passive movement of sodium and water into the bowel lumen, same as GCC agonist, improves bowel function. It is effective in IBS-C. Dose is 8 microgram twice daily for 3 months. It is well tolerated. The major side effect are nausea and diarrhea. Modulation of gut bacteria has been seen in many of the trials, but as yet insufficient data to recommend routine use of anti gut flora modulation, which has been there. So rifaximin has not been found to be very useful to IBS-C, but for IBS-D, it has been found to be very useful. Prebiotics have not been found to be, or probiotics have not been found to be useful in the treatment of IBS. So that there are no change in stool frequency or consistency or improvement in pain, but bloating can be taken care with the probiotics. Rifaximin therapy for patients with irritable bowel syndrome without constipation, that means diarrheal, have been found useful, significant relief in IBS symptoms, bloating, abdominal pain, and loose watery stools. So it is found to be very useful if it is given for 2 weeks. Antidepressants have been found to be very useful. Paroxetine SSRI, selective serotonin reuptake inhibitor, has been found to be useful. Tricyclic antidepressant, which I just mentioned earlier, has been found to be very useful. Paroxetine reduces the acceleration of the orocecal transmit. It is useful in IBS-C. Citalopram has been found to be useful, decreases pain, blunt perception and tactile distinction, decreases magnitude of the increased gastrocolic reflex. So, according to the patient's symptoms, according to the severity of the pain, you can use all the drugs which I have just mentioned to you. So, identify key patient characteristics, educate and reassure the patient, optimize the treatment, as I just mentioned. Along with that, lifestyle and dietary modification should be provided to these patients. According to predominant symptoms, you can have the quality of evidences and explain them to the patient that this drug is going to be very useful because this is going to take care of this symptom. So educating the patient is also very important in reassuring the patient that he's not going to develop very severe disease like cancer or other things. So our aim should be from screams to smiles. A person sitting on the commode is straining, we bring laughter to him. And it has been seen in a case report longitudinal study of the PICU, as I just showed you, that motion se hi emotion hote hain. So once the abdomen is cleared of the fecal matter, PICU is very happy. This gentleman is very happy. And if the happiness is there, he's going to live 102 years not out. So, in summarization, we say win the trust of the patient, do not discard his symptoms and worries, allay his anxieties and fears of the dreaded disease like development of cancer due to IBS, approach globally his symptoms, initially treat pain abdomen with constipation or diarrhea. Some psychotherapy should be given. Anxiolytics and mood elevators can be given to modulate the gut-brain axis. So treatments are often used in combination because of the variability of the symptoms. Different treatment works for different people. Lifestyle modification is very important. Sometimes the patient come and say, I've got such an obstruction, doctor, that I should be subjected to surgery so that I get the relief from my obstruction. So you have to tell him there is no role of surgery in the treatment of IBS. Thank you very much for your patient hearing. So I'm ready to ask for any questions if you have.
Thank you so much, sir, for the wonderful presentation that you have just now showed. You have clearly explained all the details very well. I think no doctors have any question, but still, if all the delegates, doctor, if you have any questions regarding this topic, please feel free to paste it in the comment section so that I can put forward it to sir. Meanwhile, sir, we already start getting the questions. First question we received, what is the current understanding of gut-brain axis in IBS?
As I just mentioned, that there is visceral hypersensitivity. So if you put a balloon in the rectum and you put 50 cc of air in that and distend it, in a normal person, he will not he will not have any pain or discomfort. But a patient with IBS will have the development of pain and discomfort, and that is modulated through the dorsal root ganglion. It goes to through the autonomic nerves to the prefrontal cortex. So what happens that if there is a change in the bacteria, environmental change is there, the patient is having some emotional IBS burst, which is there, or the psychological trauma is there, then he is going to have leaky gut, leading to presentation of the antigens which are present in the gut, and tight mucosal junctions are broken down, and this goes into the mast cells in the intestine, leads to various cytokine releases, and this leads to the altered motility. So either the patient has got slow motility or has got hypermotility, which may be perceived as constipation or diarrhea or mixed variety, or the patient will have increased visceral hypersensitivity and pain. So a leaky gut syndrome has been found to be a good explanation. That means alteration in the gut bacteria leads to the leaky gut, which is probably the most important pathophysiological and or etiological agent.
Thank you, sir. The doctors again ask along with this question, that is, how does this impact treatment strategies?
Treatment strategies, as I just mentioned, lot of work is being done now on the gut flora. That what changes takes place in the gut flora. As I just mentioned, that lactobacilli go down and coliform bacteria are increasing in the patient with IBS. But it's still not true as to which probiotic or which live bacteria, if it is given to the patient, is going to relieve his symptoms. So there are only one study which is can be said that that's good, has been found to be good for IBS D patients, but not for IBS C and Clozy. That means there is a bacteria which is called as Clozy, which has been found to be useful in the treatment of IBS D. But still, we are very, very far away from identifying the which bacteria is going to be very helpful. Now there is a studies which are there is the a healthy gut bacteria are given as through the fecal-oral route. That means given to the patient, the fecal matter from the healthy person is introduced into the gut of the patient, and that causes. So now there are availability of the some capsules in USA which are said to be good, but to my mind today there is no drug as probiotic which is helpful for all the patients of IBS D or IBS C.
Thank you so much, sir. Next question we received, that is, what is the significance of patient history and symptoms pattern in diagnosis of IBS, and what are the red flags should alert clinicians to consider alternative diagnosis?
As I just mentioned to you, that red flag signs are very important. And it has been shown that if a patient has got unexplained anemia, the patient has got what we call as persistent fever, persistent diarrhea, rectal bleeding, severe constipation, weight loss, nocturnal symptoms of pain, abnormal bowel movements in the night, a family history of GI cancer. These are the red flag signs. And that should be, we should exclude and ask these symptoms to the patient. If they are absent, then we can make a diagnosis of IBS. As has been mentioned here, take a detailed history, do thorough examination, red flag signs should be excluded, symptoms meeting a room 4 criteria, make a diagnosis of IBS. And if you find some changes in the investigation, IBS unlikely, look for the organic pathology, investigate and treat accordingly. A rectal carcinoma can be there as a common thing. A tuberculosis of the small intestine also can present alternating constipation, diarrhea. Crohn's disease patients also present, but they have all these red flag signs in them, weight loss and all those things which are there. They have nocturnal symptoms.
Thank you so much, sir. Sir, as it is already over the time, if you allow, then we could take one more question.
Sure, no problem.
Thank you, sir. Sir, we received another question, that is, could you please enlighten on the laboratory and imaging tests in the diagnosis and management of IBS, and when are they most appropriate?
As I just mentioned, This is not a waste paper diagnosis. That means, what do I make it understand? That all the symptoms which we just mentioned as the Room 4 criteria, pain once per week minimum, this pain is associated with defecation, altered bowel habit, and constipation or diarrhea, and stool form is changing or stool frequency is changing, then it is a positive diagnosis. Now, if you have excluded all the things which are having red flag signs, yes, it is IBS, and you should go ahead and treat intensity.
Thank you so much, sir. Sir, we also received many questions. We are not taking all of them. Thank you so much for the all participating doctors for your questions. And we are extremely sorry that we didn't take all the questions as it is already over the time. Thank you so much, everyone, for joining today's session, and especially thanks to Dr. Rai that you have given your precious time to us. So, with your due permission, sir, could we close this session here?
Yes, yes. I'm very happy that I got this invitation and there was some interaction which could take place. I believe I should have finished 10 minutes earlier, then I could have taken all the questions.
Yes, sir. No, no problem, sir. But you explained it very well. I think there are no more queries there with them. Thank you so much,
Okay,
everyone,
thank
for
you. Thank you.
joining.